Now let's demonstrate the actual deep tendon reflex examination on our patient.
Welcome. I'm Dr. Timothy Conwell, and this is part 1 of a 2-part lecture series on the tracts of the central nervous system. The video you're watching now, part 1, covers the central nervous system descending motor tracts. Part 2 will take up the central nervous system ascending sensory tracts. I'd encourage you to watch both because the motor and sensory systems are best learned together. Each one makes the other make sense at the bedside. Here's how we'll build this lecture. We begin with the framework, the 2-neuron motor system, and the split between the pyramidal and extrapyramidal pathways. From there, we take on the major descending tract, the corticospinal and corticobulbar system, its origin, course, decussation, function, and lesions. Next, we go deep on the upper motor neuron lesion, reasoning from mechanism to physical sign. Then we turn to the brainstem tracts, rubrospinal, vestibulospinal, reticulospinal, and tectospinal, the postural system. And we finish by putting it all to work clinically: posturing, stroke, Brown-Séquard, ALS, and board-style localization. Keep one habit of mind front and center throughout: localization. By the end, you should be able to take a pattern of weakness and tell me where the lesion is. This single diagram is the backbone of the entire lecture. Voluntary movement is a relay of 2 neurons in series. The upper motor neuron originates in the cortex, or for some tracts in brainstem nuclei, travels down within the central nervous system and synapses on the lower motor neuron. The lower motor neuron, the alpha motor neuron, is the only cell that actually leaves the CNS to contact muscle. Sherrington called the LMN the final common pathway, and that phrase earns its keep. Cortex, cerebellum, basal ganglia, and vestibular nuclei all vote, but the LMN casts the only ballot that reaches muscle. So when you localize a motor lesion, the very first question is the problem above the LMN cell body, or is it the LMN itself? Above gives you an upper motor neuron syndrome. The muscle is intact and over-facilitated, so you get spasticity and hyperreflexia. At or below the LMN, the muscle is disconnected. You get flaccidity, wasting, and fasciculations. Fix this dichotomy now, and half of clinical neurology becomes pattern recognition. Let's be precise, because sloppy definitions cause wrong answers. The upper motor neuron has its cell body in the primary motor cortex, or in a brainstem motor nucleus, and it stays inside the CNS for its whole life. Its axon forms the descending tracts. It releases glutamate onto spinal circuitry. The lower motor neuron has its cell body in either a cranial nerve motor nucleus in the brainstem or the ventral horn of the spinal cord. Its axon exits the CNS through a cranial nerve or a ventral root and terminates on skeletal muscle, releasing acetylcholine at the neuromuscular junction. Recognize the 3 flavors. Alpha motor neurons drive extrafusal fibers and generate force. Gamma motor neurons set muscle spindle sensitivity. Beta neurons do both. Gamma tone is quietly important. It is part of why UMN lesions produce spasticity, because descending pathways bias the gamma spindle loop. The board anchor at the bottom is worth memorizing verbatim. The corticospinal tract is the prototypical UMN. The ventral horn alpha motor neuron is the prototypical LMN, and the synapse between them is the boundary that decides whether a lesion looks upper or lower. The classic organizing dichotomy is pyramidal versus extrapyramidal. Pyramidal tracts are the ones that pass through the medullary pyramids, the corticospinal and corticobulbar tracts. They arise directly from cortex and specialize in precise, fractionated voluntary movement, above all the independent finger movements that make the human hand what it is. Extrapyramidal descending tracts arise from brainstem nuclei, red nucleus, vestibular nuclei, reticular formation, superior colliculus, and they handle posture, muscle tone, balance, and gross axial and proximal control. They integrate input from cortex, cerebellum, and basal ganglia and translate it into background postural set. One warning that trips students up: the word extrapyramidal has 2 lives. Anatomically, it means these brainstem tracts. Clinically, extrapyramidal signs almost always refers to basal ganglia dysfunction, the tremor and rigidity of Parkinson's disease, chorea, dystonia. On this lecture's questions, we mean the anatomical tracts, but recognize the clinical phrase when you see it in a movement disorders vignette. This is your master reference, the whole lecture compressed into one table. Do not try to memorize it now. We will build each row in detail, but orient to its logic. Read the decussation column carefully because that column generates most localization questions. The lateral corticospinal tract crosses at the pyramidal decussation in the caudal medulla. So a lesion above it gives contralateral weakness, and below it gives ipsilateral weakness. The rubrospinal and tectospinal tracts cross almost immediately at their origin in the midbrain. The lateral vestibulospinal and pontine reticulospinal tracts stay uncrossed. The medial vestibulospinal tract is bilateral through the MLF. And notice the functional grouping that will become a theme: corticospinal for fine voluntary movement, the lateral vestibulospinal and pontine reticulospinal tracts driving extensor anti-gravity tone, the rubrospinal and medullary reticulospinal tracts biasing flexion and inhibiting extensors. That push-pull between extensor facilitating and flexor facilitating systems is exactly what produces decerebrate versus decorticate posturing at the end of the lecture. This first chapter is the heart of the lecture, the corticospinal system, the great pyramidal pathway for voluntary movement. Over the next several slides, we'll follow it from its origins in the motor cortex, through the internal capsule and brainstem, across the pyramidal decussation, and down to the ventral horn. Pay special attention to two things: where the tract crosses, because that single fact drives every localization question, and what its lesion looks like, because the corticospinal tract is the very definition of the upper motor neuron. By the end of this chapter, you should be able to do four things: trace the corticospinal tract from cortex to cord and name every landmark along the way. Apply the decussation rule to predict contralateral versus ipsilateral weakness. Relate the motor homunculus and its blood supply to the pattern of weakness a stroke produces, and distinguish the lateral, anterior, and corticobulbar divisions, including the facial and tongue rules. Keep these in view as we go. The corticospinal tract carries on the order of 1,000,000 axons on each side and is the principal substrate for voluntary movement. Two facts to fix immediately. It splits into a lateral division that crosses about 85 to 90% of fibers, and a small anterior division that stays uncrossed, and it earns the name pyramidal because it travels through the pyramids on the ventral surface of the medulla. A subtlety worth knowing for boards: only about a third of the fibers actually arise from primary motor cortex. Another third come from premotor and supplementary motor areas, and, surprisingly, roughly 40% originate in the somatosensory cortex and project to the dorsal horn, where they gate incoming sensory information. So the motor tract is partly a sensory modulating tract. The giant Betz cells of layer 5 in M1 are the classic named neurons, but they are a minority of the total. On the right is the itinerary. We will now walk landmark by landmark: motor cortex, posterior limb of the internal capsule, crus cerebri of the midbrain, basis pontus, medullary pyramid, and then the pyramidal decussation into the cord. Memorize those 6 way stations. Brainstem stroke syndromes are built on knowing what sits next to the tract at each level. The corticospinal tract begins in the motor cortex, which is mapped somatotopically as the motor homunculus. Two features of that map do real clinical work. First, the body is laid out with the lower limb on the medial surface, curling down into the interhemispheric fissure at the paracentral lobule, and the face and hand on the lateral convexity. Second, the map is grotesquely distorted. The hand and face occupy enormous territory because they demand the finest fractionated control. Now overlay the blood supply. The anterior cerebral artery feeds the medial surface and the leg area. The middle cerebral artery feeds the convexity, the face and arm. This is why a board vignette that says weakness of the contralateral leg with relative sparing of the face and arm is an ACA territory stroke, whereas contralateral face and arm weakness sparing the leg is MCA. You are reading the homunculus through the lens of vascular anatomy. That single overlay answers a remarkable number of stroke localization questions. Let's make the homunculus concrete. On the left is the primary motor cortex, the precentral gyrus, Brodmann area 4, in medial and lateral views. In the center is the somatotopic map, and notice two things that do real clinical work. First, the sequence. The lower limb and foot sit on the medial surface, curling into the interhemispheric fissure, while trunk, upper limb, hand, and finally face and tongue march down the lateral convexity. Second, The distortion. The hand and face command a wildly disproportionate share of cortex because fine fractionated control is expensive. Now overlay the blood supply. The anterior cerebral artery feeds the medial leg area, the middle cerebral artery the lateral face and arm area, and the clinical pearl writes itself. The position of a lesion on this map predicts exactly which body part goes weak. From the cortex, the fibers funnel through the corona radiata into the posterior limb of the internal capsule, where the entire tract is squeezed into a compact band. That compactness is clinically dangerous. A tiny lacunar infarct here, often from chronic hypertension, can produce a pure motor hemiparesis affecting the whole contralateral body. Remember that the corticobulbar fibers sit just anterior at the genu, and ascending sensory fibers just posterior. The tract then enters the midbrain in the middle 3/5 of the crus cerebri. Here, CN3 exits medially, so a lesion produces Weber syndrome, ipsilateral third nerve palsy with contralateral hemiparesis. In the pons, the descending fibers are broken into bundles by the transverse pontine nuclei and lie near the 6th and 7th nerve nuclei, the setup for Millard-Gubler syndrome. The fibers then regather on the ventral medulla as the pyramid, adjacent to the hypoglossal nucleus and medial lemniscus, the medial medullary syndrome. The unifying principle, everything on this slide is above the pyramidal decussation. So any lesion here produces contralateral weakness. Hold that thought. The crossing is the next slide, and it flips the rule. This is the crossing, and it is the hinge of the whole tract. In the caudal medulla, at the cervicomedullary junction, roughly 85 to 90% of corticospinal fibers cross the midline. Those crossed fibers become the lateral corticospinal tract and descend in the lateral funiculus of the cord to control the contralateral limbs. The small uncrossed remainder becomes the anterior corticospinal tract. Everything you need to localize a pure motor lesion flows from this one fact. If the lesion is above the decussation, cortex, internal capsule, midbrain, pons, upper medulla, the weakness is on the opposite side of the body because those fibers are destined to cross. If the lesion is below the decussation in the spinal cord, the weakness is on the same side because the fibers have already crossed and are now descending ipsilaterally. Drill this until it is reflexive. Right-sided cortical stroke, left-sided weakness. Left cervical cord hemisection, left-sided weakness below the level. The decussation rule is arguably the single highest yield sentence in clinical neuroanatomy. Here is the whole corticospinal journey on one figure. Trace the 9 numbered steps with me. From the primary motor cortex, fibers funnel through the corona radiata into the posterior limb of the internal capsule, then the cerebral peduncle of the midbrain, the basis pontis, and gather as the pyramid on the ventral medulla. At step 7, the decussation, look at the inset. Roughly 85 to 90% of fibers cross to become the lateral corticospinal tract in the lateral funiculus, while the 10 to 15% that stay uncrossed become the anterior corticospinal tract. Follow them to the ventral horn, the lateral tract to distal muscles on the opposite side, the anterior tract to axial and proximal muscles bilaterally. Every localization rule we use flows from that one crossing. After crossing, the lateral corticospinal tract descends in the lateral funiculus, the dorsolateral white matter of the cord. Note the internal somatotopy. Cervical fibers lie more medially, sacral fibers more laterally. That arrangement explains central cord syndrome, where a central lesion preferentially damages the medial arm fibers and produces weakness that is worse in the upper limbs than the lower. The tract sheds fibers at every level from cervical to sacral, and they terminate in the ventral horn. For most muscles, the synapse is onto interneurons, but for the distal limb, especially the hand, corticospinal axons synapse directly onto alpha motor neurons. These corticomotor-neuronal connections are a primate specialization and are the anatomical reason humans can move individual fingers independently. The tract preferentially targets the lateral motor pools that drive distal musculature, while medially placed fibers reach axial pools. When this tract is lost, it is precisely that fine, fractionated distal control that disappears first and recovers last. Now the function, because a board question will ask you to distinguish what this tract does from what the brainstem tracts do. The lateral corticospinal tract is the master of fractionated distal movement, the ability to move one finger without moving its neighbors. That is its signature, and it is why loss of this tract devastates fine dexterity, while leaving cruder proximal and postural movements relatively preserved, since those are supported by the brainstem systems. It provides speed and precision for goal-directed limb movement, and it executes the skilled motor sequences that the premotor and supplementary motor areas assemble. Do not forget the somatosensory contribution. Those S1 origin fibers projecting to the dorsal horn let the motor system preset sensory gain during movement, so you are not distracted by the predictable feedback your own movement generates. If you remember one sentence, remember the maroon banner: precise, voluntary, fractionated movement of the contralateral distal limbs, especially the hand. Everything about the corticospinal lesion is the negative image of that sentence. This table walks the tract from top to bottom and pairs each level with its classic lesion and name syndrome, exactly the way boards test it. At the cortex, an MCA or ACA infarct gives contralateral weakness with the homuncular pattern we discussed, plus cortical signs like aphasia or neglect that tell you the problem is high. In the internal capsule, a lacunar infarct, the hypertensive small vessel lesion, gives a pure motor hemiparesis, the whole opposite side, face, arm, and leg weak in equal measure, with no sensory or cortical signs, because the tract is so compact there. In the brainstem, the tract is flanked by cranial nerves, which gives you the crossed syndromes. Midbrain. Weber with an ipsilateral third nerve palsy and contralateral hemiparesis. Pons. Millard-Gubler with sixth and seventh nerve findings. Medulla. Medial medullary syndrome with tongue deviation from 12th nerve involvement and contralateral loss of position sense from the medial lemniscus. Then you cross into the cord, and the rule flips. A lateral corticospinal lesion in the cord causes ipsilateral weakness below the level. If it is a hemisection, that is Brown-Séquard, which we will dissect later. The whole table is really just the decussation rule applied at successive levels. Memorize the logic, not the rows. Here is the clinical fingerprint of a corticospinal, that is, upper motor neuron and lesion. Group them in your mind as too much and too little. The positive release phenomena come from removing descending inhibition, spasticity, hyperreflexia, clonus, and the pathological reflexes. The negative phenomena are the loss of cortical command, weakness, and loss of fine dexterity. Spasticity is velocity dependent. Move the limb faster and you feel more resistance than a sudden give. The clasp knife phenomenon, hyperreflexia, and clonus reflect an unrestrained stretch reflex. The Babinski sign, an upgoing great toe with fanning, is the famous one. It is normal in infants before myelination, but pathological afterward and signals corticospinal dysfunction. The Hoffman sign is its upper limb analog. Pronator drift is a lovely sensitive sign of subtle weakness. The arm sinks and pronates because the supinators, which are cortically favored, fatigue first. Finally, the crucial negative, in a pure UMN lesion, there is no significant muscle atrophy and no fasciculations early on, because the lower motor neuron and its muscle remain connected. That single distinction, bulk and fasciculations preserved, is what separates this picture from a lower motor neuron lesion, and it is tested constantly. The anterior corticospinal tract is the small minority of corticospinal fibers, roughly 10 to 15%, that decline to cross at the pyramidal decussation and instead descend uncrossed in the anterior funiculus. Here's the twist that boards like. Many of these fibers cross near their target level through the anterior white commissure. So functionally, axial control ends up bilateral. Its job reflects that bilaterality. It governs axial and proximal muscles, the trunk and shoulder girdle, and contributes to posture and to stabilizing the trunk while the limbs do skilled work. Because the innervation of these axial muscles is bilateral, a one-sided lesion produces little trunkal weakness. The intact hemisphere covers the midline muscles. This is the same redundancy principle you will meet with the corticobulbar tract in a moment, where most cranial nerve nuclei receive bilateral cortical input and are therefore protected from unilateral lesions. You will not often see the anterior corticospinal tract as the star of a vignette, but understanding it explains why trunk control survives a unilateral corticospinal lesion, and it reinforces the crossed versus uncrossed logic that runs through the whole system. This figure sets the two corticospinal divisions side by side, and the contrast is the whole point. The lateral corticospinal tract, the crossed majority, descends in the lateral funiculus and drives skilled, fractionated movement of the contralateral distal limbs. The anterior corticospinal tract, the uncrossed minority, descends in the anterior funiculus, then crosses segmentally through the anterior white commissure, giving it bilateral control of axial and proximal muscles. Read the functional summary at the bottom as a compare and contrast, crossed versus segmental, lateral versus anterior funiculus, distal skilled movement versus postural trunk control. Reproduce that contrast, and you understand the corticospinal system. The corticobulbar tract is the cranial nerve counterpart of the corticospinal tract, the pyramidal pathway for the head and face. It arises from the lateral inferior part of the motor cortex, where the face and tongue live on the homunculus, and it descends through the genu of the internal capsule, just anterior to the corticospinal fibers. As it travels through the brainstem, it sends fibers off at each level to the motor nuclei of the cranial nerves. Now, the single most important organizing principle: most cranial nerve motor nuclei receive bilateral cortical input. Each nucleus is driven by both hemispheres, so a lesion of one corticobulbar tract usually causes little deficit. The other hemisphere compensates. This is why unilateral upper motor neuron lesions spare most of the face and cause only subtle findings. But there are two crucial exceptions that receive predominantly contralateral input: the part of the facial nucleus serving the lower face and the hypoglossal projection to the genioglossus. Those two exceptions generate the classic central facial palsy and the tongue findings we will use to separate upper from lower motor neuron cranial nerve lesions on the next slide. Memorize the exceptions. The rule takes care of itself. This slide is a perennial exam favorite, so let us make it airtight. When a corticobulbar lesion strikes above the facial nucleus, in the cortex, internal capsule, or upper pons, you get a central upper motor neuron facial palsy. The forehead is spared because the upper face keeps its bilateral input from the intact hemisphere. The contralateral lower face droops because it has crossed only input. This central facial weakness usually travels with a hemiparesis on the same side as the facial droop. When the lesion is at the facial nucleus or the nerve itself, a lower motor neuron lesion, the prototype being Bell's palsy, the entire half of the face is weak, forehead included. The patient cannot wrinkle the brow or close the eye on that side, so the single discriminating question is, can the patient raise the eyebrow? Forehead involved means peripheral lower motor neuron. Forehead spared means central upper motor neuron. Finally, contrast the two bilateral syndromes. Pseudobulbar palsy is bilateral upper motor neuron, spastic dysarthria and dysphagia, a brisk jaw jerk, and the striking pseudobulbar affect of involuntary laughing or crying. Bulbar palsy is bilateral lower motor neuron, a wasted, fasciculating tongue, flaccid speech, and an absent jaw jerk. ALS can produce both because it attacks upper and lower motor neurons simultaneously, which is exactly why it makes such a good teaching case. Pearl, volitional emotional dissociation. In a central UMN facial palsy, the lower face is weak to command, yet the patient may still smile symmetrically with genuine emotion because mimetic emotional facial movement travels a separate extrapyramidal pathway. This is the corticobulbar tract in full, the pyramidal pathway for the head and face. Arising from the lateral motor cortex, it passes through the genu of the internal capsule and peels off at each brainstem level to the cranial nerve motor nuclei. The organizing principle is in the table on the right. Most nuclei receive bilateral cortical input, which builds in redundancy, and that is why the two crossed-only exceptions are so heavily tested. The lower face through the facial nucleus and the genioglossus through the hypoglossal nucleus receive predominantly contralateral input. Hold that thought because it is the entire basis for separating a central from a peripheral facial palsy and for reading a deviating tongue. Now we turn to the clinical keystone of the whole lecture, the upper motor neuron lesion. Everything to this point described the corticospinal system working normally. Here we study what happens when it's damaged. I want you to leave this chapter understanding the UMN syndrome mechanistically, not as a list of signs to memorize, but as the predictable consequence of removing cortical control from the spinal cord. Get this, and spasticity, hyperreflexia, and the Babinski sign stop being facts and start being logic. Your goals for this chapter are 4. Contrast the upper and lower motor neuron lesions across tone, reflexes, atrophy, and the pathological reflexes. Explain the disinhibition mechanism that produces spasticity, hyperreflexia, clonus, and the Babinski sign. Describe how the syndrome evolves over time, from acute flaccidity to chronic spasticity, and localize an upper motor neuron lesion along the neuraxis from the company its weakness keeps. Let us define it carefully and then explain it. An upper motor neuron lesion is damage to the descending motor pathway anywhere from the cortex down to the point just above the anterior horn cell, or for the cranial nerves just above the motor nucleus. So it encompasses cortex, corona radiata, internal capsule, the brainstem tracts, and the corticospinal tract within the cord. Older texts call it pyramidal insufficiency. Now the mechanism, which is the whole point, the descending pathways do two jobs at once. They deliver voluntary commands, and they continuously regulate and inhibit the spinal cord's own reflex circuitry. When you cut them, you lose both. Losing the command produces weakness of fine voluntary movement. Losing the inhibition unleashes the stretch reflex. That is your hyperreflexia and clonus. Meanwhile, the extensor facilitating brainstem tracts, no longer balanced by cortical influence, dominate and gamma motor neuron drive to the spindles rises. The result is spasticity, a velocity-dependent increase in tone. Follow the chain on the right. Each mechanistic step maps to a physical sign. And note the final line, the one that separates UMN from LMN. Because the lower motor neuron and its muscle are still connected, there is no early atrophy and no fasciculation. Learn the syndrome this way, and you will never again have to rote memorize the sign list. You will regenerate it from first principles. A subtlety that catches students. The upper motor neuron syndrome is not spastic from the first minute. It evolves. In the acute phase, the first hours to days after a cord transection or a large stroke, you see a state of shock, spinal shock below a cord lesion, or cerebral diascosis after a stroke produces flaccid paralysis, low tone, and depressed or absent reflexes. The limb looks, transiently, almost like a lower motor neuron problem. Over the following days to weeks, the reflexes return and then overshoot into briskness, tone climbs, and the Babinski sign appears. By the chronic phase, weeks to months out, you have the full, familiar upper motor neuron picture: spasticity, hyperreflexia, clonus, an extensor plantar response, and eventually some disuse atrophy. So the exam trap on the maroon banner is real. If a vignette describes an acute lesion with flaccid weakness and absent reflexes, do not reflexively call it lower motor neuron. Ask about the time course. Spasticity is the chronic signature. Flaccidity can be the acute face of the very same upper motor neuron lesion. A clean way to organize the upper motor neuron syndrome, and one that examiners like, is to split the findings into positive and negative signs. Positive signs are release phenomena, abnormal activity that appears because inhibitory control has been removed. These are the spasticity, hyperreflexia, clonus, clasp knife resistance, and the pathological reflexes like Babinski and Hoffman. Also in this column, a little counterintuitively, is loss of the normal superficial cutaneous reflexes, such as the abdominal reflexes. Those disappear with corticospinal damage. Negative signs are the loss of function features: weakness, loss of fine dexterity, slowness, fatigability, and the inability to fractionate finger movements. These reflect the missing cortical command. The clinical value of this split is prognostic and therapeutic. Positive signs, spasticity, spasms, are what we treat with agents like baclofen or botulinum toxin. Negative signs, weakness and clumsiness, are far harder to fix and often dominate the patient's actual disability. Keep the two columns distinct. A question may ask which category a given finding belongs to. Before we leave the upper motor neuron syndrome, let's sharpen a distinction students routinely blur: the different kinds of abnormal tone and where each localizes. Spasticity is the corticospinal signature, velocity-dependent, with the clasp knife give, traveling with hyperreflexia and a Babinski. Contrast it with rigidity, which is velocity-independent, a constant lead pipe or cogwheel resistance, and which points not to the corticospinal tract, but to the basal ganglia. Paratonia, or Gegenhalten, is an involuntary variable resistance that rises with speed and effort, seen in frontal and diffuse cortical disease. And clonus is simply the rhythmic extreme of the spastic, hyperactive stretch reflex. The single discriminator to carry away. Only spasticity is velocity dependent, and only the corticospinal signs come with a Babinski. This is the table to know cold, the master comparison of upper versus lower motor neuron lesions. If you memorize nothing else from the lecture, memorize this grid, because it is tested relentlessly and it is the tool you will actually use at the bedside. Walk down it. Paralysis, spastic versus flaccid, tone, increased versus decreased, reflexes, brisk versus depressed, pathological reflexes and clonus, present versus absent, then the discriminators that clinch the diagnosis, atrophy and fasciculations. In an upper motor neuron lesion, there is no early atrophy and no fasciculation because the lower motor neuron is intact and keeps the muscle innervated. In a lower motor neuron lesion, the muscle is denervated, so it wastes rapidly, twitches with fasciculations, and shows the reaction of degeneration on EMG. Notice the one row that is the same in both columns. Superficial cutaneous reflexes are lost in either lesion, so they do not help you distinguish. And the distribution row is a quiet, high-yield point. UMN weakness follows a regional pyramidal pattern and is never focal, whereas LMN weakness maps to a specific nerve or root. When a case combines features from both columns, think of a disease that hits both neuron populations, the prototype being ALS, which we will return to. Let us make sure you can actually perform and interpret the pathological reflexes because the boards will describe the maneuver and expect you to name the finding and its localization. The Babinski is elicited by stroking the sole of the foot with a blunt object running up the lateral edge and across the ball. The normal adult response is toe flexion. The pathological response, the positive Babinski, is dorsiflexion of the great toe with fanning of the others, and it points to corticospinal tract dysfunction. The Hoffman sign is the upper limb analog. You flick the nail of the middle finger, and a positive response is reflex flexion of the index finger and adduction of the thumb. It suggests corticospinal involvement, particularly cervical. Clonus is elicited by a brisk, sustained dorsiflexion of the ankle, producing rhythmic beats. Sustained clonus reflects a hyperactive, disinhibited stretch reflex. Two developmental caveats worth points. The Babinski response is normal in infants until about a year of age, before corticospinal myelination completes, so an upgoing toe in a neonate is expected, not alarming, and a couple of beats of clonus can be physiologic in an anxious patient. It is sustained, non-fatiguing clonus that is pathological. This is the payoff slide for the whole UMN block, a decision ladder for localizing an upper motor neuron lesion along the neuraxis. Boards give you a constellation of signs and ask, where is the lesion? Work from the accompanying features, not the weakness alone. If the weakness comes with cortical signs, aphasia, neglect, a focal seizure, or a clear homuncular pattern favoring face and arm or leg, the lesion is cortical. If instead you get a dense, perfectly proportioned hemiparesis of face, arm, and leg with no cortical and no sensory findings, that is the internal capsule, the classic pure motor hemiparesis of a lacunar stroke. If you see a crossed pattern, a cranial nerve palsy on one side and hemiparesis on the other, you are in the brainstem, and the level is given by which cranial nerve is out. And if you find a sensory level, sphincter dysfunction, and limb signs with a completely normal face, you are in the spinal cord because the cord has no face representation. Practice running any vignette down this ladder. The presence or absence of face involvement, cortical signs, crossed findings, and a sensory level will localize almost every case you are handed. With the pyramidal system in hand, we move to the brainstem descending tracts, the extrapyramidal postural system. These are the pathways students most often understudy and then regret on exam day. As we cover the rubrospinal, vestibulospinal, reticulospinal, and tectospinal tracts, hold on to two organizing questions for each one. Does it cross and does it drive flexor or extensor tone? Those two answers will carry you through the posturing that follows. For the brainstem tracts, aim to accomplish three things. Identify the origin, decussation, and cord level of each tract, rubrospinal, the two vestibulospinal, the two reticulospinal, and tectospinal. Predict each tract's effect on flexor versus extensor tone, and explain how the balance among them governs posture and anti-gravity tone. Those three will make the posturing chapter effortless. The rubrospinal tract originates in the red nucleus of the midbrain tegmentum, which itself is a relay for cerebellar and cortical input. Its fibers cross almost immediately in the ventral tegmental decussation and descend in the lateral funiculus, running right alongside the lateral corticospinal tract. In humans, it projects mainly to cervical levels, giving it an upper limb bias. Functionally, the rubrospinal tract facilitates flexor tone and inhibits extensor tone in the upper extremities. In many mammals, it is a major motor pathway, but in humans, it is relatively minor and largely subsumed by the corticospinal system. So why do we care? Because of posturing. The rubrospinal tract's flexor bias to the arms is exactly what produces the flexed upper limbs of decorticate posturing when a lesion sits above the midbrain and leaves the red nucleus intact and disinhibited. Hold that idea. When we compare Decerebrate and Decorticate rigidity, the rubrospinal tract is the hero of the Decorticate arm. Isolated rubrospinal lesions are essentially never tested on their own. Its exam value is entirely in that posturing story. Here is the rubrospinal tract in detail. It arises from the magnocellular red nucleus in the midbrain, crosses almost immediately in the ventral tegmental decussation, and descends in the lateral funiculus of the cord, close alongside the lateral corticospinal tract, reaching mainly cervical levels. Functionally, it does two reciprocal things. It facilitates flexor tone and inhibits extensor tone in the upper limbs. Look at the clinical correlation. A lesion above the red nucleus releases this flexor drive and permits the arm flexion of decorticate posturing, while a lesion below it removes the drive and the arms extend. In humans, the tract is relatively minor, but its logic is the key to posturing. The lateral vestibulospinal tract arises from the lateral vestibular nucleus, also called the nucleus of dieters, which receives vestibular input from the eighth nerve and modulating input from the cerebellum. Critically, it descends uncrossed, ipsilateral, in the anterior funiculus, and it runs the entire length of the cord. Its function is to be the great anti-gravity pathway. It powerfully facilitates extensor muscle tone, especially in the legs, to keep you upright against gravity, and it adjusts that tone as the head moves so that posture stays stable. Think of it as the tract that stiffens your legs to hold you standing. Clinically, this tract is the engine of decerebrate rigidity. When a lesion sits below the level of the red nucleus, the extensor facilitating vestibulospinal and pontine reticulospinal systems are released from higher control and dominate, driving the whole body into rigid extension. So pair this tract in your memory with the lateral corticospinal and rubrospinal picture. Extensor drive from vestibulospinal, flexor drive from rubrospinal, and the level of the lesion decides which one wins. 3 tracks on one slide because they share the theme of postural background control. The medial vestibulospinal tract arises from the medial vestibular nucleus, descends bilaterally in the medial longitudinal fasciculus, and reaches only the cervical and upper thoracic cord. Its job is head stabilization, the vestibulocolic reflex that keeps your head steady and coordinates it with eye movements. Because it is a short tract, it does not influence the legs at all. The reticulospinal tracts come as a functional pair, and the exam point is that they oppose each other. The pontine, or medial, reticulospinal tract descends ipsilaterally and facilitates extensor and axial anti-gravity tone, teaming up with the lateral vestibulospinal tract. Think of it as proextensor. The medullary or lateral reticulospinal tract inhibits extensor tone and contributes to locomotor rhythm, autonomic control, and descending pain modulation. Think of it as the anti-extensor counterweight. That push-pull between the pontine proextensor tract and the medullary anti-extensor tract is another lever in the posturing mechanism. When descending cortical drive to the medullary inhibitory system is lost, extensor tone runs unopposed, so both the reticulospinal balance and the rubrospinal vestibulospinal balance feed into the same final story about decerebrate and decorticate rigidity. This figure pairs the 2 vestibulospinal tracts, and they divide the labor neatly. The lateral vestibulospinal tract, from the lateral nucleus of dieters, descends uncrossed the entire length of the cord and is the great anti-gravity pathway. It powerfully facilitates extensor tone, especially in the legs, to hold you upright. The medial vestibulospinal tract from the medial nucleus descends bilaterally in the medial longitudinal fasciculus, but only to cervical levels, where it stabilizes the head and coordinates it with the eyes through the vestibulo-ocular reflex. Use the comparison table to fix the contrast. Whole cord versus cervical only. Extensor tone versus head and gaze stabilization. The tectospinal tract is the smallest of our descending pathways and the lowest yield, but it completes the set and it follows the template cleanly. It originates in the superior colliculus, the tectum of the midbrain, which is a reflex integrator for visual and auditory input. Its fibers cross immediately in the dorsal tegmental decussation, descend in the anterior funiculus, and terminate only in the cervical cord, where they drive neck musculature. Its function is reflex orientation, the automatic turn of the head and neck toward a sudden sight or sound. The "what was that?" reflex, coordinated with the visual grasp reflex. You will rarely see it lesioned in isolation, and boards ask little beyond its origin in the superior colliculus, its immediate decussation, and its head-orienting function. Know those 3 points and move on. Here's that pathway, drawn out in full. Follow the arrows, the superior colliculus, an immediate cross at the dorsal tegmental decussation down the anterior funiculus, ending in the cervical cord on the neck muscles. Use the picture to lock in the shape of the tract. And that is genuinely all you need here. Of every descending pathway, tectospinal is the lowest yield, so its origin, its crossing, and its orient the head job are the 3 facts to keep. Here is the extrapyramidal system consolidated into one grid. Read the 2 columns that carry the exam weight, crossed or not, and net effect on tone. Rubrospinal and tectospinal both cross immediately at the midbrain. The lateral vestibulospinal and pontine reticulospinal tracts stay ipsilateral. The medial vestibulospinal tract is bilateral through the MLF. The medullary reticulospinal is mostly ipsilateral. Now the functional memory hook at the bottom, which is genuinely the most useful thing on the slide. 2 tracts drive extension, the lateral vestibulospinal and the pontine reticulospinal. 2 provide the opposing flexor or anti-extensor influence, the rubrospinal, which flexes the arms, and the medullary reticulospinal, which inhibits extensor tone. When the corticospinal command and the cortical drive to the medullary inhibitory center are removed, the extensor pair dominates. That imbalance is precisely the physiology of decerebrate rigidity, which we take up next. Keep this grid open in your mind as we move into posturing. This short chapter is where the anatomy becomes a bedside sign. Decorticate and decerebrate posturing are nothing more than the tract balance we just built, made visible in a comatose patient, and the level of the lesion relative to the red nucleus decides which posture you see. Learn this well. Posturing not only localizes the injury, it grades its severity, and its progression is one of the most ominous signs in clinical medicine. This chapter has 3 objectives. Differentiate decorticate from decerebrate posturing by both the limb pattern and the lesion level relative to the red nucleus. Explain the tract tug-of-war that produces each posture, and interpret posturing and its progression toward flaccidity as a sign of herniation, including where it falls on the Glasgow Coma Scale. Start with the anatomy, because posture maps directly onto lesion level. Decorticate posturing, abnormal flexion, results from a lesion above the midbrain in the cerebral hemisphere's internal capsule or thalamus. The arms flex and adduct toward the chest with flexed wrists and fingers, while the legs extend and rotate inward. The classic mummy baby. The mnemonic that never fails. Decorticate. The arms flex toward the core. Decerebrate posturing, abnormal extension, results from a lower lesion at the midbrain or upper pons, specifically below the red nucleus, classically between the red nucleus and the vestibular nuclei. Now everything extends, arms extended, adducted and pronated, legs extended, head arched back, jaw clenched. Remember the E in decerebrate for extension, and the clinical principle in the banner, the lower the lesion, the worse the posture. A patient who progresses from decorticate to decerebrate is descending, literally and prognostically, because the damage is marching caudally down the brainstem. That transition is an alarm, and it leads directly into the herniation discussion in 2 slides. This figure maps posture directly onto lesion level, which is exactly how you should think about it. On the left, decorticate posturing, abnormal flexion, comes from a destructive lesion above the midbrain in the cerebral hemisphere's internal capsule or basal ganglia. The arms flex toward the core and the legs extend. On the right, decerebrate posturing, abnormal extension, comes from a lower lesion at or below the midbrain in the upper pons. Now all four limbs extend. The dashed line at the midbrain is the pivot. Commit the rule: the lower the lesion drops, the worse the posture, and the worse the prognosis. These illustrations show what the postures actually look like at the bedside because you will need to recognize them on site. Decorticate: arms adducted and flexed, wrists and fingers curled onto the chest, legs extended, flexion toward the core. Decerebrate: arms adducted but extended and pronated, legs stiffly extended with the feet plantar flexed, everything rigidly extended. And the take-home beneath them is the one that matters clinically. Decerebrate extension reflects a lower, more caudal, and more dangerous injury than decorticate flexion. Now the mechanism, which is where the brainstem tracts pay off. Think of posture as a tug-of-war between flexor-facilitating and extensor-facilitating pathways refereed by the cortex. In decerebrate posturing, the lesion sits below the red nucleus, so it removes the rubrospinal flexor drive to the arms. What survives are the extensor facilitators, the lateral vestibulospinal and pontine reticulospinal tracts, and they now run without opposition. On top of that, the lesion cuts cortical drive to the medullary reticulospinal tract, which normally inhibits extensors, so the extensor brake is released too. Extensor tone therefore dominates every limb, and the patient extends rigidly. In decorticate posturing, the lesion is higher, above the midbrain, so the red nucleus is intact, and freed from cortical control, it is actually disinhibited. Its rubrospinal output now dominates the arms, flexing them. But in the legs, the vestibulospinal and reticulospinal extensor drive still wins, so the legs extend. That is why decorticate posture splits the body, flexed arms, extended legs. The single conceptual pivot is the red nucleus. If the red nucleus is above the lesion and intact, the arms flex, decorticate. Drop the lesion below the red nucleus and you lose that flexor influence, so the arms extend, decerebrate. One nucleus explains the entire difference. Why do we care so intensely about posturing? Because it marks severe, deep brain injury and dangerously raised intracranial pressure from trauma, hemorrhage, a large stroke, tumor, or a global insult like hypoxia or cerebral malaria. Two clinical anchors. First, laterality. Decorticate posturing is often unilateral, opposite a focal hemispheric lesion, while decerebrate is usually bilateral, from midline brainstem compression. Second, the Glasgow Coma Scale. Abnormal flexion scores 3, abnormal extension scores 2, and the slide from one to the other, and then to flaccidity, tracks a brain herniating from the top down. One caveat: a brief, self-limited tonic posturing after a forceful blow in sport, the fencing response, is a transient event, not herniation, but it still marks a real impact, so the athlete comes out and is assessed. In this final chapter, we put the entire framework to work. I've chosen high-yield syndromes that force you to use the descending tract logic actively: capsular and cortical stroke, the crossed brainstem syndromes, Brown-Séquard hemisection, and ALS. For each, resist the urge to pattern match a diagnosis. Instead, reason from the deficits to the level, because that is exactly what the boards and your patients will ask you to do. By the end of this final chapter, you should be able to localize the lesions behind pure motor hemiparesis, the cortical stroke syndromes, and the crossed brainstem syndromes. Analyze a Brown-Séquard hemisection using the 3 different crossing points of the motor, dorsal column, and spinothalamic pathways, and explain how ALS produces combined upper and lower motor neuron signs while sparing sensation. These are the questions the boards love. Let's earn them. Before we move into the clinical cases, this overview gathers every descending tract we've studied into a single reference. Origins in the cortex on the left, the decussations and course through the brainstem in the center, and the pathways within the spinal cord on the right, each tract labeled A through G. Use it as a checkpoint. For each tract, you should now be able to state its origin, whether it crosses, where it runs in the cord, and its function. If any row still feels shaky, this is the moment to pause and review, because from here on, we apply this anatomy to real lesions. Stroke is where the corticospinal anatomy earns its keep, because vascular territory maps onto the homunculus and the brainstem. Run the table. An anterior cerebral artery stroke takes the medial motor strip, the leg, so you get contralateral leg weakness out of proportion to the arm and face, often with abulia from frontal involvement. A middle cerebral artery stroke takes the convexity of face and arm with relative leg sparing, and in the dominant hemisphere adds aphasia. The lenticulostriate lacune in the posterior limb of the internal capsule gives the pure motor hemiparesis, face, arm, and leg equally weak, with no cortical or sensory signs because the whole tract is compressed into that tiny region. In the brainstem, you get the crossed syndromes, Weber in the midbrain with a third nerve palsy, Millard-Gubler in the pons with sixth and seventh nerve findings, each contralateral hemiparesis paired with an ipsilateral cranial nerve deficit. Every one of these is an upper motor neuron pattern, contralateral weakness that becomes spastic and hyperreflexic over time. What differs is the company the weakness keeps. Cortical signs push you high, a crossed cranial nerve puts you in the brainstem. The clean absence of both localizes to the capsule. That is the entire logic of motor stroke localization. This is the stroke localizer, and it rewards a careful read. On the left, the motor homunculus of the precentral gyrus and the sensory homunculus of the postcentral gyrus, both arranged leg medial to face lateral. On the right, the internal capsule in cross-section, frontopontine fibers in the anterior limb, corticobulbar fibers at the genu, and the corticospinal fibers in the posterior limb, dense and therefore dangerous. Walk the table. A medial ACA stroke takes the leg, a lateral MCA stroke takes the face and arm, and a small posterior limb lacune takes the whole opposite side equally, with no cortical signs. Medial to lateral on the cortex, compact and vulnerable in the capsule, that's the localization in a sentence. Brown-Séquard Syndrome, hemisection of the spinal cord, is the perfect integrative case because it forces you to track 3 tracks with 3 different crossing points at once. Picture a lesion cutting the left half of the cord. The lateral corticospinal tract has already crossed up in the medulla, so below the lesion it is descending ipsilaterally. Damage it and you get ipsilateral upper motor neuron weakness below the level, spastic, hyperreflexic. The dorsal columns also ascend ipsilaterally until they cross in the medulla, so you lose proprioception and vibration on the same side below the lesion. But the spinothalamic tract crosses within 1 to 2 segments of where it enters the cord, so by the time its fibers are ascending at the level of the lesion, they represent the opposite side of the body. Cut them, and you lose pain and temperature on the contralateral side, beginning a level or 2 below. So the signature is a dissociation, motor and dorsal column loss ipsilateral, pain and temperature loss contralateral. At the level of the lesion itself, you also get a band of ipsilateral lower motor neuron signs and complete sensory loss from destruction of the ventral horn and entering roots. If you can explain Brown-Séquard from the crossing points, you truly understand the descending and ascending systems together. Amyotrophic lateral sclerosis is the case that ties the whole lecture together because it attacks both motor neuron populations simultaneously, the corticospinal upper motor neurons and the anterior horn and bulbar lower motor neurons. The result is a picture that mixes both columns of our master table in the same patient, sometimes in the same limb. The pathognomonic combination is a finding you would otherwise call contradictory, a brisk, hyperactive reflex in a muscle that is wasted and fasciculating. Normally, atrophy and fasciculation mean lower motor neuron, which should give you a depressed reflex. But here, the coexisting upper motor neuron degeneration keeps the reflex brisk. Alongside that, you may see spasticity and Babinski signs together with flaccid weakness and fasciculations elsewhere. Bulbar onset disease combines pseudo-bulbar features from upper motor neuron loss with a wasted, fasciculating tongue from lower motor neuron loss. And note the crucial negative in the little table. There is no sensory loss because ALS spares the sensory pathways. That combination, mixed upper and lower motor neuron signs with entirely normal sensation, is the fingerprint of ALS and a favorite board discriminator. If you can explain why a wasted muscle can still have a brisk reflex, you have mastered the UMN LMN distinction. Here is the entire lecture on a single page. The neuraxis running down the center with the pyramidal system on the left and the extrapyramidal system on the right. Trace it top to bottom. From the cortex, the corticospinal and corticobulbar fibers funnel through the internal capsule, corticospinal in the posterior limb, corticobulbar at the genu. They pass through the crus cerebri of the midbrain, the basis pontis, and gather as the medullary pyramid, where the great majority cross at the pyramidal decussation. The crossed fibers descend as the lateral corticospinal tract to synapse on the ventral horn lower motor neuron. Running in parallel, the extrapyramidal tracts arise from brainstem nuclei you can see at their levels. The red nucleus and superior colliculus in the midbrain, the vestibular and reticular nuclei spanning pons and medulla. They set tone, balance, and orientation. If you can reconstruct this diagram from memory, the levels, what tract or nucleus lives at each, and where the crossing happens, you can answer essentially any descending tract question by reading the picture in your head. This is the mental model I want you to walk out with. Here's the entire lecture distilled into one diagram, pyramidal on the left, extrapyramidal on the right, with the neuraxis running down the middle. Trace it once, top to bottom, cortex to internal capsule, through midbrain, pons, and the medullary pyramid where the great majority cross, then down the cord to the lower motor neuron. On the right, the four brainstem systems and their jobs, rubrospinal flexor tone, vestibulospinal extensor tone and balance, reticulospinal postural and locomotor gain, tectospinal reflex head turning. And the clinical box ties it off with the rule that has organized everything. Above the decussation, contralateral, below it, ipsilateral. If you can redraw this slide from memory, you own the material. Let us compress the anatomy into the handful of facts that generate the most board questions. First and most important, the lateral corticospinal tract crosses in the caudal medulla at the pyramidal decussation, which gives you the contralateral above, ipsilateral below rule. The rubrospinal and tectospinal tracts cross immediately at the midbrain. The lateral vestibulospinal and pontine reticulospinal tracts stay uncrossed and drive extension. The medial vestibulospinal tract is bilateral through the MLF and only reaches the cervical cord. For the cranial nerves, corticobulbar input is bilateral to almost everything, with two crossed-only exceptions you must know. The lower face via the facial nerve and the genioglossus via the hypoglossal nerve. Those exceptions are the entire basis of the central facial droop and the tongue deviation questions. And to connect with the sensory system, the dorsal columns cross in the medulla while the spinothalamic tract crosses within a segment or two in the cord itself. That difference in crossing level is what produces the ipsilateral versus contralateral dissociation in Brown-Séquard. 6 pearls. If you own these, you own most of the localization logic. This is a pattern recognition cheat sheet. The reverse lookup you will actually run during an exam. Read the left column as the clinical picture and the right column as the answer. Contralateral weakness with a cortical sign like aphasia or neglect is cortical, usually MCA. A dense hemiparesis that hits face, arm, and leg equally with nothing else is the internal capsule lacune. Contralateral leg weakness sparing the arm and face is ACA. An ipsilateral cranial nerve palsy paired with contralateral hemiparesis is a brainstem crossed syndrome, and the specific nerve tells you the level. Ipsilateral motor and vibration loss with contralateral pain and temperature loss is Brown-Séquard. Brisk reflexes in a wasted, twitching limb with completely normal sensation is ALS. Forehead sparing facial weakness with a hemiparesis is a central upper motor neuron facial palsy. Whole hemiface weakness, including the forehead, is peripheral lower motor neuron Bell's palsy. Memorize the shape of each pattern. Board questions are engineered around exactly these discriminators, and if you can move from picture to localization in a single step, you will answer them quickly and leave time for the harder items. This final overview is your one-glance master map of all 7 descending tracts. On the left, their origins in the cortex and brainstem. In the center, their appearance in cross-section as they decussate and descend. On the right, their courses through the cervical, thoracic, lumbar, and sacral cord in lateral and anterior views. The color-coded legend, A through G, lets you test yourself, cover the descriptions, and name each tract's origin, crossing, and function from its color alone. This is the single best slide to return to when you review, and a perfect companion to the flashcards waiting for you after the lecture. We've reached the review. What follows is a single take-home card for every descending tract grouped into the two systems. Treat it as your pre-exam checklist for each tract, origin, course, decussation, function, and the one pearl that shows up on tests. Don't just watch these go by. Say each answer to yourself before I do. First, the pyramidal system, the direct high-fidelity command line for voluntary movement. The lateral and anterior corticospinal tracts and the corticobulbar tract to the cranial nerves. 3 cards coming up. The lateral corticospinal tract, mixed cortical origin, down through the internal capsule and brainstem, crossing at the pyramidal decussation, then descending in the lateral funiculus to the contralateral distal muscles. It is the classic upper motor neuron. Its pearl, a posterior limb capsular lacune, gives a pure motor hemiparesis, face, arm, and leg equally weak, with no cortical or sensory signs. The anterior corticospinal tract, the uncrossed minority in the anterior funiculus, crossing segmentally through the anterior white commissure to control axial and proximal muscles bilaterally. Because that control is bilateral, a unilateral lesion barely dents trunk function, which is exactly why the trunk is spared after a one-sided corticospinal injury. The corticobulbar tract, from the lateral motor cortex through the genu of the internal capsule to the cranial nerve motor nuclei, most of them bilaterally innervated. Remember the 2 crossed-only exceptions, the lower face and the genioglossus. Forehead spared means a central lesion, forehead involved means a peripheral one, and the tongue deviates toward a lower motor neuron lesion, away from an upper. Now the extrapyramidal system, the brainstem postural pathways, rubrospinal, the 2 vestibulospinal, the 2 reticulospinal, and tectospinal. 6 cards. For each, keep asking, does it cross and does it drive flexion or extension? Rubrospinal. From the red nucleus, crossing immediately in the ventral tegmental decussation, down the lateral funiculus to cervical levels, facilitating upper limb flexor tone. Anatomically reduced in humans, but once disinhibited, still able to flex the arms, which is why it dominates the Decorticate picture. Lateral vestibulospinal, from the nucleus of Deiters, uncrossed, the whole length of the cord, driving extensor and anti-gravity tone, especially in the legs. Run unopposed, it produces decerebrate extension. Think of Deiters as the extensor engine. Medial vestibulospinal, from the medial vestibular nucleus, bilateral in the MLF and cervical only. It stabilizes the head and coordinates it with the eyes. It never reaches the legs. Contrast it point for point with the lateral tract. Pontine or medial reticulospinal, ipsilateral, anterior funiculus, and proextensor. It works with the lateral vestibulospinal tract to raise anti-gravity tone. Pontine equals positive to extension. Medullary or lateral reticulospinal, mostly ipsilateral, in the lateral funiculus and the anti-extensor brake. It inhibits extensor tone under cortical command, lose that cortical drive, and the brake comes off, feeding decerebrate extension. Pontine versus medullary is the extensor tug of war. Tectospinal, from the superior colliculus, crossing immediately, anterior funiculus, cervical cord only. Reflex turning of the head towards sights and sounds. Lowest yield of the group. Know its origin, its crossing, and its function, and move on. A brief word on sources. The anatomy and clinical correlations in this lecture rest on the standard neuroscience references. Blumenfeld's Neuroanatomy through Clinical Cases, Candle's Principles of Neural Science, and Potestas, and Gartner's Textbook of Neuroanatomy, supplemented by the current primary literature on corticospinal organization. They are listed here for those who want to read deeper, and I encourage you to. Every diagram in this lecture will make more sense the second time you meet it in a good text. Before we close, let me leave you with 3 things. First, if this lecture reinforced the value of a rigorous, systematic approach to neurological localization, I want you to know about a resource that takes that approach much further. The Clinical Picture. The Clinician's Complete Guide to Neuromusculoskeletal Evaluation, Initial Consultation and Narrative Report, and SOAP Charting and Documentation is a comprehensive clinical reference that carries you through the complete neuromusculoskeletal workup, the history, the physical examination, neurological and orthopedic evaluation, the initial consultation, and full documentation, including the narrative report and SOAP charting. It is the only text that takes you from examination findings all the way through to a finished clinical record in a single, concise volume. Whether you are preparing for board examinations, entering your clinical rotations, or you simply want a reference that translates neuroscience into practical documentation, this textbook belongs on your desk. It is available now on Amazon. The link is on your screen and in the description below. Second, put today's material to the test. This lecture includes a complimentary board preparation flashcard set, 50 board-style examination questions, each with a detailed explanation and rationale, available now at theclinicalpicture.com/lecture series. And here is my challenge to you. Don't just read the answers. Reason through each question first, and then reveal the explanation. That process of active recall is one of the most powerful ways to strengthen retention, sharpen your clinical reasoning, and build the confidence you will need on your boards and with the patients you will care for throughout your career. And third, this is part one of a two-part series on the tracts of the central nervous system. Today, we followed the descending motor pathways from the cortex to the muscle, and we learned to read a pattern of weakness and answer the question every neurological examination is really asking, where is the lesion? In part two, we complete the picture, the central nervous system ascending sensory tracts, where you'll see how motor and sensory findings, read together, localize a lesion with remarkable precision. I hope you'll join me there. If this lecture deepened your understanding of this important clinical topic, please subscribe, like, or leave a comment below. It genuinely helps me produce more content like this. Thank you for watching.